Welcome to the Digital Health Case Study session at the InnoHEALTH conference. This session is the first technical one following the inaugural session, is dedicated to exploring the dynamic and evolving realm of digital healthcare in India. It serves as a vital platform for sharing insights, experiences, and advancements in the field of digital healthcare. Our focus will be on the case studies that highlight the innovation and impact of digital solutions in improving healthcare delivery and outcomes. We now invite Dr. Vijay Agarwal, our session chair, to please join us on the stage. Please put your hands together for Dr. Vijay Agarwal, President, Consortium of Accredited Healthcare Organization, a crusader for continual quality improvement in healthcare. Dr. Agarwal is committed to elevating Indian healthcare to global standards through KAHO. His philosophy, people make quality, has driven the establishment of KAHO certified professional courses aimed at equipping healthcare professionals to excel in quality healthcare delivery. We welcome you, sir.
I now request Henrik Udden to please come and take the seat. Mr. Henrik Udden is the CEO and co-founder of SmartCare. He has almost 30 plus years of experience within IT and business development from MNCs like IBM and PwC, as well as from private companies. He has worked many years in the healthcare industry in different countries. He has an MBA in Business Administration and Economics from Stockholm School of Business and Stockholm University. We welcome you, sir. Next off, we have Mr. Amarjit Singh Cheema. We welcome you, sir. Mr. Amarjit Singh Cheema works as an Associate Director and Head of the Department at the Health Informatics Group, CDAC, Noida. He has just completed his successful tenure with NHA as Director, IT Operations. He has worked as a Joint Advisor, IT in TRAI. And moreover, he has 22 plus years of experience in the health informatics field and has led several projects of national importance.
Next, we have Mr. Vivek Mittal, co-founder Yugasa Software Labs Private Limited. Mr. Mittal is an accomplished technology innovator with a strong academic foundation and over 20 years of experience in technology industry. His profound expertise in artificial intelligence and machine learning has positioned him as a thought leader and visionary in the field of technology and product development. We welcome you, sir. Please put your hands together for all our panelists. Now, next we have Dr. Partha Day, founder and CEO, U4RAD. Mr. Partha Day is a healthcare transformation professional with a demonstrated history of serving the healthcare providers and payers, public health and information technology industry for over 2.5 decades. He has developed expertise in emerging technology like AI, ML, cognitive, blockchain, cloud, and digital for healthcare organization to drive better clinical and operational outcome. We welcome you, sir. Next, we have Mr. Vineet Agarwal, CIO, Paras Healthcare. Mr. Agarwal is a digital transformation specialist, a global technology leader with expertise in building the right ecosystem and successfully creating and executing multi-year digital transformation roadmap, vast consulting experience and technology implementations using AI, ML, and whatnot. We welcome you, sir. We start with our session, sir.
So thank you. Good afternoon, and I bring you greetings from CAHO, the Consortium of Accredited Healthcare Organizations. And before I start the program, I would like to first of all convey my best wishes for the early recovery of my dear friend, Professor Vijay Singh. And I'm very indebted to him and to Sachin for asking me to come here and share this platform with such an illustrious panel of my friends who are going to talk about digital health. For setting up a context, I would like to ask you, how many of you heard the name Klaus Schwab? Anybody heard? Who is Mr. Klaus Schwab? So ladies and gentlemen, Klaus Schwab is the executive chairman and founder of World Economic Forum. And in the year 2016, 14th of January, this gentleman is what he described the emergence of the fourth industrial revolution. And I'll just try to read a para or two from his speech exactly. He says that we stand on the brink of a technological revolution that will fundamentally alter the way we live, work, and relate to one another. In its scale, scope, and complexity, the transformation will be unlike anything humankind has experienced before. We do not yet know just how it will unfold, but one thing is clear: the response to it must be integrated and comprehensive, involving all stakeholders of the global polity, from the public and private sectors to academia and civil society. The first industrial revolution used water and steam power to mechanize production. I'm sure you guys understand that was in the year 1784 was the first industrial revolution. The second one in 1870 used electric power to create mass production. The third used electronics and information technology to automate production, and that was in the year 1969. Now a fourth industrial revolution is building on the third, the digital revolution technologies that is blurring the lines between the physical, digital, and biological spheres. There are three reasons why today's transformation represents not only merely a prolongation of the third industrial revolution, but rather the arrival of a fourth and a distinct one: velocity, scope, and systems impact. The speed of current breakthroughs has no historical precedent. When compared with the previous industrial revolutions, the fourth is evolving at an exponential rather than a linear pace. Moreover, it is disrupting almost every industry in every country. And the breadth and the depth of these changes herald the transformation of the entire systems of production, management, and governance. The possibilities of billions of people connected by mobile devices with unprecedented processing power, storage capacity, and access to knowledge are unlimited. And these possibilities will be multiplied by the emerging technology breakthroughs in fields such as artificial intelligence, robotics, the Internet of Things, autonomous vehicles, 3D printing, nanotechnology, biotechnology, material science, energy storage, and quantum computing. Ladies and gentlemen, he had gone on to say that this industrial revolution is going to impact healthcare the maximum. And it is a paradox that the healthcare people are the least prepared for it. And that's where I feel that the panels such as these have become extremely important. And we are very fortunate to, of course, we are living now in an era where we are seeing unfolding of the powers of the digital health ecosystem. So now, without much ado, I will like you to see some of the case studies, some of the case examples of how digital health is impacting us in various spheres. And to start the ball rolling, our opening batsman is Henrik Udden, and he is from Sweden. You already heard the eloquent introduction of the kind of the collaboration that we are having with Sweden. So I'm sure Henrik will take it one step forward. Thank you. Thank you.
This one works? Yes. Thank you so much for having me here. Yes, I am one of these companies that Rebecca was speaking about, one of these Swedish companies that have come to India, and we have, I would say, an India first policy, because everything that we have done, we have made it here in India, together with doctors in India. So my name is Henrik Udden. I'm the CEO and co-founder of SmartCare. And we work with healthcare clinics, not hospitals as of today, but healthcare clinics in India. So this here is, oh, here's the mic. This here is myself outside our office in Noida. And we, I don't need, thank you. But I am from Sweden, but I actually grew up and lived and worked in a total of 9 countries so far. I did my university studies in Sweden, and I have worked within IT and healthcare for companies like PwC and IBM for many, many years. My co-founding partner, Surendra Kumar, or SK, he's originally from Delhi, but he's lived more than 20 years now in Sweden, actually. I was born in Thailand, lived 5 years in Egypt, 5 years in New Zealand, and all around in so many countries. But my father was actually the managing director for Ericsson here in Delhi, so I've been here so many times since 1991. Me and Surendra, me and SK, we developed SmartCare over the years with many doctors here in India, and we did it for a reason. Of course, everybody knows about the future, which is ABDM and the digitalization, which is coming. But actually, sadly, SK's father passed away. Only 66 and very healthy, but the lab report came quite late to the doctor. It was, of course, on paper. But if everything would have been digital and the doctor would get notification that the lab report was done, most probably SK's father would still be around. So this was also a compelling reason for us to do. So Sweden is quite ambitious when it comes to e-healthcare. We have an agency which is called E-hälsomyndigheten in Swedish, and they work a lot to provide technical solutions for the citizens of Sweden. So some of the things that they provide is, for example, the platform for digital prescriptions. So all doctors in Sweden write digital prescriptions and started doing it about 10, 15 years ago. And they are all stored on a platform, so any pharmacy can access. Me as a citizen, I can access and see. But any pharmacy in Sweden, you just show your ID and you pick your medicine from any pharmacy, because they also have the prescription in there. Just a small comparison between Sweden and India. We are only 10 million people in Sweden. So it's quite a small country, but we have 4 doctors per 1,000 persons in Sweden. But in Sweden, it's actually almost impossible to meet a doctor, which is a bit ironic, right? If you're really sick, of course, you can meet a doctor, but it's absolutely difficult. A few years back, Sweden opened up for private clinics and hospitals. So now this really pushed the digitalization, which means it becomes easier as a citizen to meet a doctor, but over video consultation. So SmartCare. We built this platform with, of course, inspiration from Sweden and Europe, but we built everything here with our developers here in India. And it's a full solution for clinics, all specialities, everything from patient journals, e-prescription, of course, and appointments. But it's not only that, because we see digitalization a bit wider. So we actually help the clinics to become visible also over the internet. So we give web page, we work with social media, Google My Business and everything, because everything is interconnected. Of course, we have the video features as well. So one of our aims is to get out into rural areas with our solution in order to extend the reach of healthcare across India. We've been around for just a few years, but we already have 3,200 clinics onboarded on our platform. And I think I would say that we have encountered all possible strange situations. So over the years, we have a system which is actually being used, and it works. A lot of focus from our side is on data privacy and security. Of course, being Swedish, we have the most secure car, I think, in the world, which is Volvo. So we are focused on safety and security and data privacy. So we have also taken into account GDPR, which I think it's patient data privacy bill, right, in India. So a lot of focus has been on this. So this here is Professor Dr. Vishal Singh, and he's one of our early movers. He loves technology. He has a clinic in Faridabad with 5 doctors, so he makes a good use of our digital platform to schedule appointments between his doctors and to set up treatment plans for his patients. I also want to mention one more doctor. Her name is Smita Goel, and she is a homeopathic doctor. She is absolutely not tech savvy, fully no. She was onboarded on SmartCare, and she got herself a tablet. And she is now doing digital prescriptions. She, of course, has a pharmacy in her clinic, so she sells her medicines as well, because we have the full integrated solution. And she, I think, does 25 electronic prescriptions every day. Just a few words on our IT roadmap. I mean, both myself and SK, we have a history from IBM. IBM, of course, have IBM Watson for healthcare. So a lot of focus from our side is to bring new technology in order to support doctors and patients and to improve the patient's outcome. We launched back in 2021 with the web app and mobile app for prescriptions and the basic things. And since then, we have added and linked pharmacy, pathology. So we have large clinics as well with 20+ doctors who have their own lab, they have their own pharmacy. So with the fully integrated solution, it becomes quite easy to run the clinic. Looking into the future, we are looking a lot into wearables like smartwatches and other wearables in order for that data to be captured, also to become shared with doctors. I want to mention one thing which we call smart pharma. So an ambition that we have, because we have doctors and increasing number of doctors with video functionality, I want to have a QR code in the pharmacy. So when a patient comes without a prescription, can scan the QR code, have a video consultation, get the prescription for the right medicine, and it automatically flows to the pharmacy so he gets the right medicine, and hopefully also addressing a little bit on the unnecessary use of antibiotics. Looking into the future, it's all about validating and it's all about data, and we've heard this previously here. We have started looking into AI and to support our doctors. Of course, there are solutions out there already, but we're going to be working very closely on the ground with the realities for the doctor to validate and to make use of AI. So thank you. I'm so glad to be here in the conference. Thank you, Tav. Thank you, Sachin, I think in the back. We have a booth outside, so please come and visit us, and we can show you also a little bit about SmartCare. Okay.
Thank you, Henrik, for your very, very crisp and smart presentation, just like the smart solution that you have developed for the clinic, which is absolutely the need. And I'm sure that very soon you are going to grow exponentially and not linearly. So let's come next to Amarjit Singh Cheema ji.
Thanks, Henrik, to setting up the context. Like, as you mentioned, digital health and hospitals are now well equipped. So I'm going to cover about the challenges what we have faced during the implementation of any hospital management information system. Before I begin, I'm a little sleepy, so I want to be interactive with you. So this question is to students. How many of you are IT background or know about anything IT? Just raise your hand only. Very few. So mostly you are from the health policy side or health domain side or from a hospital side. Thank you very, very much. Because according to the audience, I'll cover up this session. So I'm working in this hospital management information system from last 22 years. And during this tenure, we have implemented 3,000 plus hospitals. And we face a lot of challenges which still need to be addressed by the audience like you. With the support of you, we can address those challenges. So before we begin, let's see that what areas we are covered in a hospital management information system. So we can call it as a HMIS, and the name of HMIS is to generate the electronic medical record, capture the clinical records through doctor, through nurses, through lab reports, and the aim is to digitalize this record so that that could be help for the statistical analysis, trends, forecasting, machine learning, and even provide you the decision support, and doctor will get the less time. Like Henrik mentioned in his presentation, on 1,000 patient, only 0.9 doctor is available in India. And if you see, if a doctor needs to go through all case sheets, all lab reports manually, then how much time he needs to take for a one patient? At least 10 to 15 minutes. So that's why the digitalization is very much important, to not only to manage the crowd, not only to reduce the waiting time, but to create electronic medical record which provide you the decision support system. And the rapid availability of complete information can improve the earlier diagnosis, speed up treatment, and reduce the patient length of stay. Mind length of stay. Right now, any big hospital length of stay varies from 7 days to 15 days. And if you see one patient stay on one bed, waiting of another patient for a particular surgery are more than 6 months, a year, or 2 years in some cases. So if you reduce the length of stay with your digital efforts, provide the decisions to doctor, provide the required information on his desktop or mobile, that could be going to be one of the advantage. We all evidence the advancement in various areas. So we see that now hospitals are very, very well equipped with nicely, if you visit to the even government hospital like AIMS or any super specialty hospital of the government, they are equivalent to the Fortis hospital in terms of the infra. So this part we have achieved as a well achieved in terms of the infra, what we earlier in 10 or 15 years back. If you talk about the infra of medical equipment or automation like DICOM or PACS machines, now we are well equipped. Doctors are using, radiologists are using ultrasound, ICUs are well equipped. Everybody is using everything to get the decision support. But the challenge is the clinical records, your OPD prescription, your IPD discharge summaries, or your clinical notes. Still, it's challenge. It's challenge. I am saying that the people has now getting the lab reports from Lal's lab and government hospital as it digitalized. Here I'm talking about your prescriptions. So let me ask you this question. How many of you get the digital prescription last time and your prescription directly downloaded by another hospital? Anybody? How many of you are aware of the ABHA ID? Good. So ABHA ID, we are happy that you people know about the ABHA ID. But if you see about yourself, how many of you have interacted last time as a teleconsultation? Very few. So see, this is the area where we need to think of that we all are using the mobile app, but we are not using mobile app for digital health. And we are talking about the technologies to improve the digital health. So in this reference, I just go through the digital landscape in 3 terms, like how we grow technology, how we go in the terms of EHR, in terms of adoption, and how we go regarding the standards, and what challenges we faced through the 20 years of journey of HMIS in government hospitals. So we started this journey, let's say in 2001, where technology is a very outdated technology of a client-based system where we need to install every software on every nurse system or any doctor system, and major target on that time only to do the billing. Standard was totally missing, maintenance is too much, cost is too much, and uses are very less. So EMR adoption at that time was zero. Then in 2003, 2007, we all upgraded to web-based technology with the blessings of Java. And at that time, we comprised some of the labs, but still standards are only ICD-10 was used. We don't use SNOMED City, we don't use any interoperability standards, and the records are only available to hospitals because there was no cloud enablement or internet facility available, and doctors are very rare using those systems for EHR. So if you see that, till then again we are capturing the only registration and billing papers from the HMIS system. The aim was not established. 2008, 2014 was the time when we improved the clouds and we started working on the various standards. So now standard was introduced, but challenge was how to interoperable it. If your application is standard compliant, let's say you use all EHR 2016 standard. EHR 2016 standard was released by Government of India in 2007. According to the mandate, all government and private hospitals should adhere those 35 standards. And these 35 international standards enable your application to interoperable in terms of one application to another application. So on that time, the challenge was, let's say Fortis application is interoperable, EHR standard compliance. But how you communicate to AIMS? So the ecosystem was missing. We need to communicate through one-to-one. There is no standard protocol on that time. So that was a very big challenge on that time. And this is the thanks to the Ayushman Bharat Digital Mission that ecosystem is provided as a digital public infrastructure where we are generating our ABHA ID and we all are connected. And if you see till now, the percentage of clinical records are very less. I'll cover up in my further slides. So ABDM is a blessings to by Government of India in India to enable like ecosystem where now I am on my PHR app getting all my clinical records of AIMS, even Lal's labs, where I can club those records and share with any doctor. But the percentage of adoption is very less and clinical records capturing is very less. So this is the one of the pictorial example. If you see left and right side are the two hospitals where we are exchanging the clinical records through ABDM. The only concern is you have a one HMIS, it's standard interoperable. We're creating the health registries through ABHA. So every patient could have a one Ayushman Bharat account, health account. So you can create your own account through our Aadhaar number or you can directly use through mobile number. You can create your ABHA account. It's just like a Aadhaar, uniquely identify you as a one patient in all hospital. So we achieved this interoperability, which makes us prescription online, lab reports online, but the facts are not like this. If you see yourself, visit to doctor or teleconsultation, so we have taken this around 500 to 1,000 survey of different patients and age groups. So we found that 86.5% are using better to go to doctor. And 64.9% doctors are using paper as a manual prescription. So digital records are missing. And ABHA ID is, impact is good. 66% we have found that ABHA ID is available. So now the adoption has started, but the government sector, the uses of 22% of mobile app only, and 21% of scan and share only. So these are the data which we captured through government scenarios. Could be it's better than in a private hospital, but if you see about the patients, this is the patients like where do you want to go? So most of cases people like to go to the private clinic near to patient, or they want to go to private hospital, but they don't want to visit to the government hospitals. So this is the scenario the challenges which we are facing like we as a patient, we always prefer to go to either nearby or any other, but we are not going to rely on a big hospitals. This is the one fact which I would like to share in one of the blog, share the comparison of the government hospital and the private hospital. And the government hospitals are very crowded. But no, this is not the now scenario. With the blessings of ABDM scan and share and automation of token management in government hospital, this is the example of AIIMS Jodhpur in August 2023 itself. Before 8 a.m., they have a crowd like this when they not adopted the scan and share and other technology. But next day, 9 a.m., the crowd is well managed. So it's not like that government hospital having a comparison with the private hospital, but the only issue is problem is like the patient's ratio as per the private to hospital then compared to government hospitals are much higher than. I'm going to cover the basic challenges which we face.
So,
Yes.
Chimaji, your time is quite up,
Yeah.
actually.
So
if
should
you
I
can-
stop?
Yeah, I mean, maybe you can take another 30 seconds to conclude,
Oh,
please.
It's really difficult to wind up. I'll cover up. I'll share
So
my
let's see
presentation.
towards the end, maybe if there are questions, we
yeah,
can
please,
try
please.
to take
Right,
it up.
right.
But because we need
So
to time.
basic challenges which we are facing, requirement and technology and administrative challenges. I'll hand over this presentation to the organizers. So you can get this presentation and try to guide it.
Well, yeah, Vivek, I think while you proceed, only thing I'll just give a comment that this ratio of 0.9 per 1,000 people and all what we talk about is again a big hoax. Please understand that 60% of these doctors are just the MBBS doctors who are, well, everybody understands, are not job ready. So I do not know which healthcare people are we talking about. And second is that if you take this ratio in the city of Delhi, I don't know, I think there must be 10 or something, not 0.9, and you go just about 100 kilometers away from Delhi, the ratio will become 0.1 or something. So it is high time that the country has a city-wise, in fact, data of the doctors, of the providers, and everybody. And unless we have that baseline data, I think we'll keep on talking about this 0.9 per 1,000, and I think you'll keep drawing very wrong conclusions. But the need for the telehealth, especially for remote areas and all that, is extremely high. Over to you, Vivek. Thank you.
Thank you, sir. And good afternoon, everybody. And thank you very much to InnoHEALTH for arranging this conference here. It is really the need of time to discuss such innovations in healthcare domain. So I'll be talking about AI chatbots. That is what we do. I am the co-founder of Yugasa Software Labs, and we have Yugasa Bot as a product, which is basically a AI-enabled platform which can develop virtual receptions for hospitals, clinics, and labs with the help of AI. So why is there a need of such product or such innovation? Is because there is a lot of traffic going in hospitals, clinics, and it is increasing every day. So the footfall in hospitals, it is increasing. The older age population is increasing at a rate higher than any other age group, which probably needs more healthcare. So, and hospitals and clinics are becoming more and more open to adopt AI and new technology. So definitely there comes a need of communication overhaul for handling the queries of all these people who are visiting hospitals. If we try to handle those queries, even the repeated queries, mundane queries, if we try to handle them manually, it is not very efficient and it is not scalable also. So an overhaul in the communication strategies of hospitals is needed, and that is where AI in healthcare comes into picture. AI in conversations for healthcare. And why we are talking about this now is because this has become possible now. The technology has evolved. There are lots of enablers which are actually supporting the whole ecosystem. Big players like Google, Facebook, WhatsApp, Microsoft, they are doing a lot of research in the domain of conversational AI. Then we are seeing products like ChatGPT, and people or patients are also showing trust. User also showing trust in products like these. They are now getting habitual to interact with bots rather than humans. And the latest generation, like you guys are sitting here, and the generation which includes millennials and Gen Z, this population is completely online, right? They are very much tech savvy. They are on chat platforms, and they are kind of impatient also. They want results immediately, right? So automation and bots, they are actually helping this whole ecosystem to get what is required. Now, technology has done its part, right? So it depends on us how we use it, right? If we don't understand technology, if we try to move away from it, if we try to ignore it, that's not going to help, right? So we have to join hands with technology. We have to adopt it. Sooner the better, right? So we are better than this guy here on this screen. So definitely we should embrace technology. And when we talk about AI chatbots in healthcare, so one picture which comes into mind is something which is visible on the left-hand side on the screen, which is like a bot is talking to a patient, understanding the problem with the patient and giving a clinical suggestion, or suggesting some kind of medicines or prescribing some kind of medicines. That is not the reality right now, and that is not going to be the reality very soon, because this AI or this technology is not going to replace doctors. It is not there to give clinical suggestions to the patients. The technology is not evolved that much yet, and regulations are there which will not allow this thing to happen very soon. So when we talk about AI into healthcare, that is more on the administrative side. The one which we see on the right-hand side of this slide, that is how AI chatbots are being used in healthcare today for the administrative purposes, for actually creating virtual receptions. Whatever a human receptionist can do, these bots are capable of doing all those tasks, sometimes at an efficiency close to that of a human efficiency, or sometimes even more than that. Now, when we talk about bots, chatbots, then there is a whole range of chatbots which is available. So one chatbot is the button-based chatbot, where the bot keeps on asking the questions. It gives some options to the user to select one of the options as the answer, and that is how the flow of conversation proceeds further. So there is no AI needed in this particular flow, and this is also good. Like if it solves the purpose, it's good. But that is one type of chatbots. Then other type of chatbot, which we see on the rightmost of this slide, use generative AI, where a user asks questions to the bot, and those can be very complex questions. Like bots like ChatGPT have made us believe that very complex questions can be answered by bots. So in this example, we see that the user is giving a document to the bot and asking it to summarize it and give top 5 highlights of the document. So these are generative AI bots. Another type of bot is a mix of two, which uses AI as well as button-based flow, where bot can handle an open-ended question from the user. Also, it can ask questions to the user. So we have to see what is best for our particular use case, our hospital, right? So it is not that the best of the technology, which is generative AI, the state-of-the-art technology, is the only thing which we have to use. We have to use whatever is best for, whatever is the best solution for our institution, right? Now, these are some of the use cases which we have implemented for various hospital chains across India. And before I go into this use case, one important thing to notice over here is that these bots are available on WhatsApp. These screens are live screens of bots on WhatsApp. And as I mentioned initially, that big players like WhatsApp, Google, they are also supporting the whole ecosystem. And WhatsApp is, I think, way ahead of other players in this race. So 65 crore users in India today use WhatsApp. I think all of us who are sitting in this hall, we use WhatsApp, we have WhatsApp in our hands, in our mobiles, right? So that is how easy it is to actually make your bot or your technology available to someone in India through WhatsApp. So you don't really need anyone to install a new app. App uninstall rate is very high in India today. If an app is not used for 38 days, that there's a research that app, there are 80% chances that app will get uninstalled from a mobile, right? But that never happens with WhatsApp. Probably we might have changed our phone 4 times in last 8 years, but we never replaced WhatsApp with any other chat app. That is the user loyalty of WhatsApp, and that is why having a bot on WhatsApp makes a lot of sense, and that is what WhatsApp has also realized, and they are developing the ecosystem around that. So in this particular use case, which we see on the screen, OPD appointment booking is happening for one hospital, where the user is coming and saying hi to the bot. Then bot greets the user from the name, and it picks the phone number of the user from the WhatsApp profile, and then continues the journey of OPD appointment booking, which probably a receptionist would also do the same way. It will ask that which doctor you want to book an appointment with, and this software, this whole system is integrated with the hospital management system of the hospital at the back end. So when it is bringing out the time slots of the doctor, these are real time time slots available for that doctor on that particular date, right? So that is OPD appointment booking use case, and this use case can be implemented, or such use cases can be implemented in multiple languages. In this screen, we see that bot switching its communication in Hindi, and then it can create a payment link on the fly, separate payment link for separate customers, and it can generate tokens. Now, another very interesting use case which bots are implementing
Vivek,
today.
you have 1 more minute.
Oh,
Okay.
that's too short. Okay, so I'll try to skim up. So promotions, like we all have probably experienced it, that many businesses are now promoting themselves on WhatsApp, and that is what hospitals are also doing with call to action buttons. By the way, these promotions are not promotions like on SMS. These promotions are backed up by bots. So whenever a user clicks on any button, bot has the capability of holding a conversation in depth with that user related to that promotion. Then a missed call use case, where one hospital promotes its missed call, user gives a call on that number, it gets disconnected after 2 rings automatically, and bot takes the number of that user from the missed call and reaches out to that person on WhatsApp saying, hey, you called us, let me help you. So just like a human would do, right? Then OP to IP conversion, IPD registration, complete IPD registration can be done on bot. Then these bots can be available right on Google, where your customer is searching for you. From there itself, you can start hand-holding that customer, that patient, right? And e-commerce of medical products on WhatsApp, that is also supported now. So pharmacy integration. And in public health, we are doing some bots for training ASHA workers in some of the states. So I'll wrap it up here. This is a QR code to actually try one such bot. You can scan this QR code right now, and a bot will open up in your mobiles, in your WhatsApp. You can just say hi, and you can enjoy the journey from there. It is a sample journey though. It's not linked with any real hospital at the back end, but you will get a feel of it, how it works on the bot. Thank you.
Thank you, Vivek. I think invite Parthaji, please come. And it was an excellent presentation, and I am sure that you can well imagine, the life is becoming virtual. So therefore, a lot part of the real hospital is becoming virtual. And therefore, the receptionists, the front office people who were supposed to be there, virtual front office people will be in the form of these bots. And I think this is definitely a very big application which is going to happen. In fact, even the mobile technology, as we are talking, I am told that in US, they have come out with this phone called Humane, where it will be in the form of a small tablet on your collar. And in fact, even if I go to Paris, I will be speaking in my language, and the person could hear in French, and I could listen to in various language interpretations, everything. I don't need a screen, no, nothing. So In a way, I mean, I'm just saying that this bot thing will go to a very, very different level in very, very less time. Over to you, Parthaji, please. Thank you.
Good evening, sir. So, sir, we have 10 minutes? Yes. Okay, fabulous. So I'll try to make it in 5 and I'll keep 5 for some discussions. I think that would be very important. Okay. I represent a company called U4 Technologies. We are a born-on-cloud digital company. We try to do everything digital. So is like, we don't have a visiting card. I don't have a visiting card. So if somebody asks me how you share your number, I just use this. Anybody can scan the QR code and the number, including my all informations like company address, email, everything gets stored. The challenge with visiting card is that typically it gets lost. People do collect, I do collect in conferences cards from everyone, but then when I need that person, I generally don't get that card. So we try to be digital in various ways. Born on cloud means is whatever we do is everything is on cloud. We have got no server in the company. Typically, people bring their own laptop and they do it. They can work from anywhere. Doesn't matter where they are. We typically promote a work culture where people can be sitting anywhere and they can perform the work. We try to manage performance as an indicator for anyone to be in the organizations. So that's the way we try to look at it. We run 2 different programs, if I may call, internally in the organization. One, we focus on technology. We are trying to develop technology, and also there is a service organization where we provide point-of-care services in a complete digital manner under a different brand name called X-Ray Digital, where we go to people's home and do a lot of tests, including X-ray, ECG, pulmonary function test, and so many other tests, whatever is possible to ensure the clinical quality is equal or better than what is being done in the hospital. We run a lot of a public screening program. We do participate in TV screening program with the Government of India, and we do cases in the places where people may have not visited. So we are currently running 5 districts in Meghalaya. There are names I'm sure in this group there will be hardly anybody has heard about. In U4RAD organizations, what we do is that we try to build various technologies. Various technologies which is very easy to build, easy to implement, has very high impact. So that's the way our technology building selection process and the use cases are. So if anyone asks us that, what we build, I typically call that we have built some utility. We have not very, we do talk about AI, etc., but very honestly, from core of my heart, how much of AI has been in real use, there is a question mark. I have opportunity to work with a company called IBM. I used to be a part of IBM Watson team. I spent 11 plus years over there. So I have not tried to do what I used to do in IBM. So we thought, let's try to build something which will be very useful for the people, very easy to implement. While we were talking about the number of doctors, let's talk about the 2 specialist numbers. And I just Googled it to make sure that I'm not making a wrong number. How many number of our radiologists in the country? Any guess? 16,000, yeah. So Google told me 20,000. Practicing doctors as per IRA around 18,000. Who are really in practice, like retired, not practicing, if you leave them, is around 16,000. Your number is perfect. So then I don't need to do any calculation. It's a very difficult calculation. You have to see how many in thousands and all this. Number is so less, it will not even come. How many cardiologists we may have in the country? Any guess? Ajay, one point, I thought this clock is working. I have not started my clock. I thought still it is having 10. So I don't know. Oh, you will not play. Okay. So honestly, I don't know how much I spoke. 2 minutes? 4 minutes have gone. Okay. 4 minutes have gone. Okay. That's fine. Fantastic. Okay. So cardiologist numbers are less than 15,000. So let's talk about 2 tests which is being mostly done. X-ray is the mostly performed cases. ECG is the most performed cases. What could be the number of X-ray and ECGs being done in the country? in millions, billions, correct? So depending on how you look at the number is so high even nobody need to guess it. The point I'm trying to make is the number of people available to report those are very and few. So our idea is that is there any way we can make them more productive? If you have to add more people, it takes a huge amount of time to train the doctors into this. First, add more doctor in the MBBS things. Like Dr. Agarwal said that, they are not so-called employable because the kind of a training that we provide that requires more training for them to actually work on the real life. And then if they become radiologist or cardiologist, then another 6, 7, 8 years of adding to that. So today, even if we think that we will increase the number, nothing would happen tomorrow. So only one way to look at it, is there any way we can make them more productive? If there are 15,000 people, can they work as 30,000 people? Can their productivity be boosted up by double? So what we are trying to do is that we have tried to find out that what is the time each of these doctor takes while they are doing any clinical reporting. Let's take a very easiest example of somebody is reporting a chest X-ray. Okay, if someone is doing a chest X-ray report, what is the time it takes? Let's say on a lower side, average 1 minute. In that 1 minute, and we have done the detailed analysis of this several times, is that typically they spend less time in deciding whether the chest X-ray is normal or what is the abnormality in the chest X-ray. They spend more time in preparing the report or making the report. So everybody is working on the problem of image analytics and trying to make the doctor more productive. We also do work, okay, don't get me wrong. Image analytics is a great thing to do. But the time that we save by implementing image analytics and if not having a doctor over there, that's quite far. It is not yet matured enough. Here AI for us is augmented intelligence, where we are helping a doctor to be more productive. And that's the way you look at it. So what we are trying to do is that we are addressing the other part of the story, that once a doctor has decided, either by reading a ECG graph or by a chest X-ray image, that what needs to go to the report, we are trying to make that process completely automated. And there is a pattern, fortunately. There is a pattern in the report what they write every time. 70% of the reports are not so complex. Of that 70% of the report, around 65 to 70% are normal. And of the 30% complex reporting actually have only 1 to 2 findings. And we have done enough of research to back up what I am telling. Now, if there is a pattern, why they need to write the same thing every day? Even if they are using the most common and popular voice-to-text software, they have to talk, right? They cannot avoid talking. So what we have done is that we have used a bot, and thanks to him, my previous speaker, he has already explained what is bot. I don't need to go there at all. So the bots are just a click away of preparing the report for the radiologist. So if a radiologist knows that I am preparing a report for chest X-ray and the chest X-ray has this finding, not more than 5 clicks, 85% of chest X-ray report can be prepared. And the 5 clicks, it takes 5 seconds, less than 5 seconds. So that's the amount of productivity increase that we're talking about. Similarly, with ECG, we're also working on the similar manner. Top 10 diagnosis is covering around 90-95% of the ECG. Now, if we can handle the top 10, our work is done. And that will have more time for the radiologist to be, or the cardiologist to be spent on the complex report where they are supposed to spend time, not on the repeated pattern of writing the same report every day. So that is something that we are working with. I thought of sharing this piece of information. So if anybody is interested to see how it works, etc., kindly connect with us. We'll be happy to show you that. Thank you very much.
Thank you, Parthaji. You spared about still 1 minute, so thank you. And we come to now our last speaker, Vijay Agarwal. So guys, he represents the real healthcare, real institution where physically patients are coming, patients are being treated, and we have to see as to how excited he is to adopt so many of these solutions and what challenges are you facing, sir?
Thank you, Dr. Vijay. Thanks to InnoHEALTH for inviting me. Unlike my fellow panelists, as was said in my introduction and as Dr. Vijay said, I am not one of those innovators. My job is to strategize and implement the right innovative solutions for the healthcare industry. So quite a few things were spoken about here. The first and foremost thing that we as healthcare service providers should be looking at is the patient experience. Now, when everyone is talking about patient experience in terms of the omni-channel experience that a patient can get, reaching out to a hospital using a bot, using an app, using this or using that, is something different. But if you talk about a patient experience in terms of the clinical outcomes is what matters the most to healthcare service providers. To give that clinical outcome to the patient, we need to empower our doctors, and that's where the right innovative solutions with clinical validations comes in. So I'm really happy to say that few things that we spoke about and Dr. Chima talked about was on the lines of HIS come a electronic health record. So electronic health record in its true sense can bring in the right clinical outcomes which are validated by the doctors in providing the right and faster clinical outcomes to the patients. And this can be done both in OPD and IPD, and we at Paris are one of those hospitals and chain of hospitals who have successfully used this solution to deliver the right outcomes to our patients. I'll take two use cases very, very simply, one from the OPD area and one from the IPD area, right? Now, look at it from a scenario. A patient walks into a doctor chamber. There is an advice given to a patient. Yes, the e-prescription goes out on WhatsApp. The doctor asks the patient to monitor the BP and the sugar. So at Paras Health app, we have Omron connected to the Paras Health using Omron Connect. So it's a device connected to the app. We have AccuCheck connected to the Paras Health app to monitor the sugar levels of the patient. The moment there is an aberration, when the vitals or when these parameters are being recorded, these aberrations are reaching out to the same doctor in real time in EMR. And that's when there is a virtual consult which is initiated by the hospital caring about the patient that goes to the patient, and then the second set of advice which is going again out to the patient in the form of an e-prescription on WhatsApp. So that's the connectivity to the patient and the outcome to the patient that one can deliver using these solutions. The second example here is in the case of IPD. So someone spoke about paper-driven reports. So there are no longer paper-driven reports. Again, the second best use case of EMR here is that the moment a lab report is ready or a radiology report is ready, the raw data and the scanned image in terms of radiology goes out to EMR, where the clinician can in real time, after the finalization of these results, can see even in the absence of a paper report being synced back to the EMR or being sent out to the nursing stations. And if the cherry on the cake, the icing on the cake, if they have the ability as clinicians to validate the scans by looking at those scans and rotating those scans as per their needs, and then take a clinical decision is what matters the most. So that's what the power of innovation alongside a clinical validation is. The third important aspect here is what about chronic diseases? So patients who move out of the hospital, get discharged from the hospital, how do you continuously monitor the health of these patients? That's where another step that we are taking in that direction is integration of devices using IOMT. So before we even look out for remote patient monitoring, before you set up, I also have worked in telecom, so I'll use some of the telecom language of knock, right? So there is a swarm of people monitoring towers, monitoring alerts, etc., etc. Same is remote patient monitoring in healthcare. So effectively, there are multiple patients who are being provided treatment at home, and there is an army of doctors, RMOs, etc., monitoring their health, nurses, etc., in real time. Now, before we do that, do we have those capabilities in terms of integrating the right devices with the right solutions? So while we are talking about all these solutions in silo, the most important part to build the entire digital ecosystem is having this seamlessly integrated together. That's what Paras stands for. Now, in this direction, we are now taking a further step of integrating these devices, not only to cater to the remote patient monitoring, but also to provide faster outcomes to our patients while they are in our premises. Someone talked about reduction of ALOS. So yes, length of stay is important. It's not only important for the patient, it's important from a business perspective as well. The faster a bed is vacated, the next patient comes in. But at the same point in time, we at Paras stand for quality outcomes in terms of delivering the services to the patients and ensuring that they are relieved or at least treated well, if not relieved, of their problems as soon as possible. Having said that, my final outcome here would be with all these solutions, the first and foremost aspect is, are they seamlessly integrating and building an ecosystem around what you are using? The second is this providing the right and a validated clinical outcome to the patient, which is validated by your doctors, which is validated by the medical professionals on the ground? Thank you so much.
So thank you, Vineet. I think you heard some fascinating talks about it. Let me just kind of give you a perspective, at least from the point of view of CAHO, my organization, that one of the foremost things that is happening in healthcare is still the healthcare continues to remain unsafe. Ladies and gentlemen, medical errors, preventable medical errors are a huge reality. And for example, I'm not sure if you can understand, in a country like United States, which is spending as much on healthcare as like the GDP of our country, and they have an accreditation system almost for 100 years as compared to our NABH, which has been there now for 18 years. Preventable medical errors are the third leading cause of death in that country. Okay? It's just after the heart attack and the our next one, stroke or. So the third one is the preventable medical errors. So the issue is this: today, we have an opportunity to use this technology. We have to see how can I use it to make a dent on this entire issue of patient safety. The thing is that you go today in any forum or anything and you will find some talk and which will talk about increasing mistrust between the healthcare providers and the patients. So we saw a slide where you found a very small percentage of people trying to go to the government hospital, and when you go to the private hospital, the sentence is like, oh, they have now become commercial, they are looting, they are this, they are that. All those kind of things are, heard about. We need to change all that. Some of that may be, there may be some amount of truth in it, but a lot of it is also misgivings. We have to understand that 40 years back, we used to take our patients for doing a bypass surgery to United States. Today we are doing bypass surgeries in almost every town and with equal amount of better outcomes. And we are doing it in about 4,000 or 5,000 US dollars, still as compared to 60,000 to 80,000 US dollars in the United States. So we should be very proud of what we are doing in this country, where we have reached. However, this is an opportunity for us. So there are going to be today a lot of applications. So for example, there are sensors have come today which can probably allow us to do the automation of the recording of the vitals of the patient, like the pulse and the respiratory rate and the blood pressure, where the nurse comes every 4 hours or 6 hours and records it. But then something can go wrong just after 15 minutes of a recording. So there is a continuous monitoring now happening just with a small patch lying under the mattress. That kind of a thing is happening. Just with the recognition of your face, people are trying to measure that whether you could be in depression. From the passive use of the data of the mobile phone, these kind of things are coming up. So I think huge number of issues, like what I said, what was described by Mr. Klaus Schwab in his opening speech in the year 2016, what he talked about the fourth industrial revolution. We are seeing today a plethora of solutions. A problem will now also come for validation. problem will come as for us to choosing between what is right and what is not so right, what needs to be scaled up, and what will probably remain on the periphery. So healthcare itself is a fragmented ecosystem, and this startup ecosystem is also fragmented. So we need to kind of work together, and it is the institutions like the Innovatio Cures, like CAHO, like many others, who have to join hands and see that we consolidate this. Any questions? I think still we may have few minutes from our time, so please ask any of the questions to your panelists. Yes, sir.
So in the Paras Health app, there are multiple areas. So one obviously is virtual, means you can book an appointment, you can do a virtual consult. It is supported with the doctor app for the doctor side, where the virtual consult can happen. Now on the doctor app, there is a 100% mobile version of the EMR which is deployed in the hospital. Now the moment there is a prescription given and there is an advice given, on the app itself, there is an area called vitals. In that vitals, other than your temperature, SpO2, etc., you will find two other areas, one for the blood sugar and one for the blood pressure. The moment you go there, it will ask you whether you want to fill it manually or you want to integrate the devices that you have. So we have integrated Omron, which is integrated via an Omron-provided app called Omron Connect, and the EcuCheck, which is integrated via Bluetooth. So as long as the device that you have purchased supports that integration, so the moment you will take a reading, the reading will automatically appear in the app without you manually filling it. Now, the beauty of this is that whatever you are recording on a daily basis, hourly basis, which is what you decide, and you also decide in terms of privacy, whether you want to share this information back to your doctor or not. So the moment you have given all the consents and you have filled in all the checkboxes, this is going into the EMR for that particular patient to that doctor. In case there is an aberration on the EMR, as in any other EMR, there are alert mechanisms. So the doctor is alerted along with their teams that, okay, for this particular patient who was advised so and so, this is the alert which is coming up. So that's when they coordinate, arrange a consult in case admission is needed or a further advice is needed. That is given during the consult, a revised prescription goes out. If there is an admission advice, it goes out along with the revised prescription. So that's the journey, and if then the patient gives a consent that yes, I want to get admitted, the entire digital flow of admission kicks in.
Have you evaluated at any stage how much admissions have been done in time, how much patients' stress has been avoided on? So this kind of evaluation has been performed at any point of time.
So this is part of the quality checks which are already happening in the hospitals. As part of this entire digital journey, every single step that we have is monitored via the turnaround times. And that's the job through reports, different reports, etc., etc. That's what quality team job is, to keep monitoring the turnaround times for different areas, whether if the patient is an IPD, then what's the turnaround time for this? If it is to be a discharge process, what is the turnaround time for the discharge process? What is the turnaround time for an admission conversion, etc., etc. So this is what the quality teams typically do, taking the output from the system itself.
So Vineet, I will say that this is a very interesting question. And I think you need to now probably capture that data in a way so that it can be published.
Yes.
You see, please understand that that is how you are going to stimulate or you're going to create confidence in people. Otherwise, we have something, we are maybe doing good thing, but unless or until you are going to capture that data as to what was happening before and what is happening now in a very, very scientific way, then only we will be able to answer the question that you are asking. So excellent question, and we need to kind of work from the healthcare. We are usually, again, there are 2-3 things that we are extremely poor at in healthcare. One, in documentation. We are very good in talking, extremely poor in writing documentation that needs to change. And second thing is documenting from the point of view of research. we start doing something new, but let us document what was happening earlier and what has happened after bringing about the change, so that you will be able to publish. And that's why, a small tiny country like Taiwan, they are publishing number of papers which will be about 20 times more than probably what we are publishing. So let's try to bring about that change. Thank you.
Thank you.
This session has been a remarkable journey through the landscape of digital health, offering diverse perspectives from the seasoned experts. As we conclude this enlightening session, I would like to express my gratitude to our esteemed panelists who have shared their expertise with us today. Thank you for your guidance and for making this discussion a truly enriching experience. Thank you so much. I now request Dr. Tavpratesh Sethi to please come forward and facilitate Dr. Vijay Agarwal. Please put your hands together.
So this is another example of the technology. You just see that whatever things were deliberated has already been captured, has been transcribed, has been edited, and is being produced here. So, great.
This is the live transcription of what just happened in this conference. The software is known by the name of Whisper, coordinated by Mr. Sachin Gaur. If you want to know more about this, you can always ask him. Thank you, sir. Now I ask Dr. Vijay Agarwal to facilitate our panelists. We start with Mr. Henrik Udden. Please put your hands together for our great panelists. Great session it has been. It has been a very informative session, very engaging. Please let your hands keep clapping for them. Next, we have Mr. Amarjeet Singh Cheema. Next, we have Mr. Vivek Mittal. Next, we have Dr. Partha Day. Lastly, we have Mr. Vineet Agarwal. Thank you so much, Dr. Vijay Agarwal. Thank you all the esteemed panelists. It was a great session, very engaging. Please take your seat.
Please do not leave the auditorium. We'll be starting with our session 3 in some time.